Good evening, everyone. I'm Clare Morris, Clinical Manager with Wound Care People. Welcome to this Wound Care Today session, Challenges of Managing Heart Failure and Lower Limb Swelling, a live panel discussion. We have 4 speakers for you this evening, Rhona Macpherson, Sylvia Marshall, Sam Blyth and Alison Schofield, and the session is supported by Essity. I think it's going to be a really interesting and useful discussion. So if you have any questions at all, put them in the comments and we will try and answer as many as we can at the end of the session. Certificates will be available later, so keep an eye out for the link at the end of the session. As you can probably see, we are broadcasting from our homes, so please do bear with us if we do experience any technical issues. Hopefully everything will go smoothly. So without further ado, I'll hand over to Alison to begin the discussions.
Hello everybody and good evening. Thank you for joining us. It's such a hot evening, I'm sure it is where you are. We're going to have such a great session this evening. Just before we start, I just want to say a really big happy birthday to Ed Russlin, who is the CEO of Wound Care People, Wound Care Today, and a very good friend of all of us. We hope you've had a great day, Ed. So let's get on to our session. The burden of wound care is growing, we know that, and the trajectory going forward is that it's probably going to increase again. And venous leg ulcers are affecting a large proportion of that burden of overall wounds. We've got an ageing population, we've got an increase in comorbidities with that, and other elements such as obesity. So is heart failure and secondary symptoms of edema going to become a real issue? And how do we tackle that? I want to just paint a picture for you of a case study. Now, we're going to call this patient Bill. And Bill is somebody who will be very familiar to you. He may be somebody who's present on your caseload at this time, or somebody that you have come across in the past. So Bill calls the GP surgery because he says he's having problems with his legs swelling and now they're starting to leak. He feels that he can't get to the GP practice or into a clinic. So the GP passes the referral on to the district nurses, and the primary reason for referral is leaky, swollen legs. So this visit is allocated to a qualified community staff nurse, and when she goes to visit the patient, she knocks on the door. The patient takes some time to answer that door, and upon opening they feel quite breathless. They're obviously not wearing any footwear or socks, the feet are swollen and the trousers below the leg are quite wet. So the nurse follows the patient through the house. He's moving slowly, he's struggling to lift his legs, almost dragging the feet. He reaches his chair in the living room and he sits down heavy into it, out of breath. So the nurse sitting opposite him asks, how can she assist him today? What is the nature of his call to the GP for this assessment at home? Bill tells her that his legs are very wet. He says they're leaking some liquid, they're very swollen. He says it's been an issue for some time, but now they're getting worse. He's finding it hard to move around the house. He doesn't really go out and he's sleeping in his chair. And he said, he can't get up the stairs to go to bed. His chair isn't a recliner, so his legs are dependent and down all the time. The nurse asks Bill about any medical conditions he might have. There's no record on her laptop of the electronic patient record system because there isn't the share with the GP, so she can't see the relevant history. He's not so sure, but he does show her a box of medications he's got. In there, she recognises some related to a heart failure medication. So the nurse assumes that he's got cardiovascular comorbidities, but she's going to have to contact the GP to get more accurate information. So who is involved in his care and when was a review last taken? We know during the COVID-19 pandemic, some services were reduced and in practice was undertaking telephone consultations with this particular, with patients on request. So then the nurse asks Bill if she can have a look at his legs. He can't lift his trouser legs because it's too tight, so he has to remove the trousers with assistance. She can see he's got bilateral swelling. It's just above the knee, but not into the thigh, not into the groin or abdomen. It's pitting when touched. The skin is taut, and areas below the knee to his mid-gaiter area, a leak in that serous fluid, persistently running like a... And there's some small areas of ulceration and excoriation where he's scratched because they're becoming fluffy in appearance. So what are the actions that we now need to consider? What is the care planning we have to put into place? So let's move on and discuss with our live multi-professional team who should be involved in Bill's care from an MDT perspective. Patients with complexities and differential diagnosis, whilst also having edema, leg ulcers, lymphorrhea, we require a collaborative approach, and it's vital to ensure appropriate referral processes are completed and all the healthcare professionals work together in management plans for good quality outcome. So we're going to look at understanding heart failure, that holistic assessment, signs and symptoms and treatment strategies, explore the option of compression, and discuss best practice guidelines. So please, share with us your experiences throughout and do give us your question. So I want to first of all come to you, Rhona. Rhona is a lead heart failure specialist nurse. And, this is something as community nurses we come across quite a lot, and we're not quite always sure how to deal with it. So could you explain to us exactly what heart failure is, and are there particular signs and symptoms that a person will experience even if they've not even had a diagnosis yet?
Yes, so heart failure really is anything that structurally or functionally stops the heart being efficient as a pump. So, for example, someone's had an MI, reduced ejection fraction. If they have arrhythmias, they may have diastolic heart failure where the heart's pumping well, but not relaxing well. There's two umbrella terms just for people to bear in mind. One is heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. And as we sort of go through the discussion, there are different ways of treating it. It's just to sort of bear in mind as well. So really, the case study that you presented gives a really, you could tick boxes there of what might be due to heart failure. And so obviously he's very breathless. He has obvious edema, reduced exercise tolerance. Other things that you might find with heart failure patients quite often have a sort of cardiac cough. So they're coughing, but it's a sort of white frothy cough rather than a productive cough that you might get from sort of respiratory disease. And so reduced ejection tolerance. And and the edema is not necessarily just in the legs. It can be around the abdomen. If it's on their chest, and obviously that's that breathlessness. And also they can get it in their arms and upper limbs as well. So that really, but I think the breathlessness and the swelling really is probably a big indication that you need to just investigate a little bit and find out if there is something going on with the heart.
That's really interesting. I'd not heard of that with the cardiac cough before, so that's a new one for me. And so if we do see signs and symptoms and we suspect this, what are the initial tests? I've heard something, a pro-BNP test. Is that something, a type of test? And who would do those things?
Yeah. So the process for diagnosing heart failure, and this will be in sort of NICE guidelines and the European guidelines, is that we take an initial history. We may do a chest X-ray and ECG, borderline bloods. But within that blood test, you've got a blood test that's called NT-proBNP. So BNP is brain butyric peptide, and it's something that's released into the blood system when the body's under stress. So the BNP in itself isn't a diagnosis of heart failure. There are other things which can raise the BNP, so atrial fibrillation, COPD, pulmonary embolism. So there's a number of things which can raise it. It doesn't necessarily mean that that is heart failure. But if you check the BNP and the BNP is negative, then you can actually be reassured that it's not heart failure, that it's likely to be another cause. So with the BNP, if they have a high reading, which is over 2,000 for the NT-proBNP, they should have an echocardiogram within 2 weeks. and if they have BNP, which is above 400 and below 2000, that's moderate risk. So that's an echo within the with 6 weeks is the current guidelines.
Okay, so that's really important, and I guess then we would refer to our GP and say, you know, we suspect this, and then they would organise these kind of the different.
Yeah, so the process may be different in different parts of the country. So some parts of the country may have a rapid access heart failure clinic, so that may be for the GP to refer into there. With the raised BNP and echo. Where we are locally, the GPs would check the BNP and then they would refer for echo. And then once we've got the echo, we can see the structure of the heart and whether there is any sort of evidence of heart failure. So it will differ slightly around the country. It usually go from GP to echo or GP to whatever sort of rapid access service they've got for heart failure.
So it's a real collaborative approach even from the first onset, isn't it?
Yeah.
So are there treatment strategies available for what we term chronic and acute heart failure? And I'm not pretending I know exactly the difference between the two. So and when is it deemed to be then acute heart failure?
Yeah, so going back to, as I was saying before, the umbrella terms for heart failure, you've got heart failure with preserved ejection fraction. So those patients have got reduced function in the left ventricle, so the pump is failing. And then you've got a group of patients with preserved ejection fraction, which may be arrhythmias, diastolic heart failure, right-sided heart failure. So the left ventricle is pumping as it should be, but something else is stopping that. So within the guidelines, the patients who have got left-sided heart failure, you will see them on a diuretic. You will see them on an MRA, which is spironolactone or clarinone. You may see them on ivabradine if they're in sinus rhythm. You may see them on a new drug, which is sacubitril valsartan, and those there to sort of support the heart and help improve the heart function. So with the patients with preserved ejection fraction, it's very much again, giving them diuretics to offload that fluid. But they wouldn't necessarily go straight onto an ACE and a beta blocker because they're not going to improve the heart function that way. But in practice, if patients are tachycardic or hypertensive, then those medications might be the best for them. So the aim is to get good heart rate control, good blood pressure control, and then offload with your diuretic.
Yeah, okay, that's so useful information, I think, for those of us who work out in community when we are looking after patients in their home, without a doubt. And I just want to ask then, Sylvia, Sylvia is a lymphedema nurse and works in Dumfries and Galloway. So, you know, I'm a tissue viability nurse, you're a lymphedema nurse, and so we used to be a district nurse, I did, and you know, we've discussed before, we come across these patients a lot, you know, with these edematous, leaking legs. If for this patient, and we've established with Rhona, she's our heart failure nurse, we've done all the tests that this patient, Bill, has heart failure, you know, what's our next steps? Can we take a Doppler? Is that a possibility?
Dopplers would be a possibility. However, I think when you look at this gentleman's history, we've got pitting edema, we've got lymphorrhea, possibility of infection. I think it would be very painful in the first instance to do a Doppler, and also the amount of fluid that's potentially in his limbs there is going to affect the Doppler reading. I think most of us from district nursing land, our training on compression has come via tissue viability nurses, and it's also been cited by NICE as good practice to take a Doppler and have a Doppler reading before we even look at putting on compression. However, we've got to appreciate that there is this huge group of people that to obtain that is almost impossible for a variety of reasons. And even when you do obtain it, the readings that are achieved by the use of handheld machines that we have available within the community can be very limited and can give almost false readings because of the situation that you're in. Certainly from a lymphedema perspective, what the British Lymphedema Society have done is they put out a consensus paper or a position document on the taking of ABPIs and the vascular state, assessing the vascular status of patients back in 2019. And basically within that, we would support that where possible, obtaining a Doppler reading is what you would wish to do in the first instance. But we should remember that that Doppler is only one part of the assessment, and what we should be doing is a complete vascular assessment, assessing if there's any muscle pain on exertion or at rest, how quickly he recovers from that, what sort of sense of fatigue is there in the calf muscle, what we've already mentioned that he's got great difficulty getting into bed, and that he's tending to sleep in the chair, all these sort of colour changes and skin changes, and you know, what sort of capillary refill does he have? These are all things that we should be assessing as part of that.
So it's that, like you say, it's that real just full lower limb assessment, and that I think people forget that ABPI is just part of that, and that British Lymphology Society guidance document is really good. And I guess an alternative could be taking toe brachial pressure index, but obviously not everybody has those systems there, or they're not trained to do that. Would that be something that could be done?
It could be done, but it's about having the correct equipment and also having the training for it, because again, chances are if his foot and his limb is that swollen, then chances are the toes are swollen as well. So that potentially has an impact on the results you're going to achieve as well.
Do you need to refer to a specialist service then? Do you need to refer to yourself as a lymphedema nurse, or to myself as tissue viability? Or, you know, could the community nurses, you know, create their care plan and manage this themselves?
Coming from a district nursing background and working in an area that up until 3 years ago didn't have a lymphedema service, my view would be, no, you don't need to refer, because we obviously didn't have that option. And I think as district nurses, we need to take a step back, because I think we hear the word sort of lymphedema and stuff like that, and we panic that it's something new and specialist and has to be done by the specialist nurse. But what we're forgetting is that anything up to about 70% of a district nursing caseload at any given point in time probably has some degree of edema in it, and a lot of those are people with ulceration. So in essence, this is really no different to treating these, bill is no different to what is already currently on their caseload. So my view would be certainly to do that initial full assessment, and then actually the quicker that we can get him into start treatment and get even a basic level of compression on is beneficial, because at the end of the day, as a nurse, you're not wanting to walk out of that house leaving somebody with open weeping wounds, puddles on the floor, risk of falling with slippage and that. You know, that's the last thing any of us would want to be doing.
Yeah, risk of assessment and everything else. And you know, I've had a few conversations this week, kind of that fear factor. And I think this really is one, that heart failure, lymphorrhea, and all that combination of do we compress, don't we compress, and things. And I'll tell you what, one of the things, sorry, Sylvia, go on.
I was going to say, and what doesn't help with that fear factor is that any of us that have done lots of research, there is very little research out there that would support you putting on compression. The majority of it is saying heart failure of any kind, just don't compress. But as a district nurse with lots of experience, you know, I can't justify walking out of a house like that and not doing something for that gentleman, even if it is basic containment and very basic low-level compression, to actually make a start at, you know, getting that basic level of compression on with an aim to build that. Now, obviously, we're not wanting to overload the heart, so you probably will have to start slowly and build gently.
Yeah, so I want to ask Rhona then on that, because that is a question everybody in the audience will be asking. Will I overload the heart if I put compression to this patient? You know, is it contraindicated from your point of view?
Yeah, so just to go back to the previous one, I realised I hadn't covered a little bit of it. So acute heart failure is a rapid onset of heart failure. It's in response to raised intracardiac pressures within the heart. Whereas chronic heart failure is sort of more, they do sort of decompensate and recover, but it's on you've got time to think about it and increase diuretics and respond to it. Whereas the acute is the one that will probably get people admitted on a 999. So with the compression of the legs, something you've got to bear in mind is that if you've got, so with your lymphedema, you've got fluid in the wrong place. With heart failure, you've got fluid overload. So if the patient's fluid overload, if you compress the legs and push that fluid back into the body, that will increase the preload and change the pressures in the heart. So that's when you can get an acute compensation with heart failure. Saying that, you know, you can't do nothing. You've got somebody who's there who's in distress and in discomfort. So what I would say is that dress the legs. If you feel that you need compression, put on the minimum compression that you can, and then get the BMP, get the echo, find out what's going on. And then if that's negative, you can increase your compression there. But what we've found really is it's the higher levels of compression that cause problems. The lower levels, which are added in gradually, the heart will actually get used to and cope with. It's that sudden change. If you suddenly put a lot of compression on the legs and push that fluid up quickly, that's when the patients decompensate and possibly end up in hospital.
Okay, so that's kind of that's just to sort of clarify that's like a acute phase, or before we've like with Bill, we've not done all the tests yet and things like that. So we just go steady, gentle, and then once we know, we can increase if that's required. Yeah. And you mentioned diuretics a couple of times, and I know I've come across patients before with chronic edema, not necessarily heart failure symptoms, and the GP's prescribed the diuretic to reduce the edema or lymphedema in the leg. And without heart failure, is that of any use or not? Because obviously them going to the toilet more and things like that.
Yeah, I mean, I think that it depends on the GP's perspective. Some people they sort of seem to sort of leap for the water tablets and compression hosiery immediately, and other ones are doing the BMP and doing the echo. So I think it's individual GP sort of feeling about what they think is doing there. I would say that there's probably a lot of people out there on diuretics who've never really been investigated. They've been given the diuretic, it's improved things, and then they've never gone on to have the BMP and the scanning done.
And I feel like with other medication, is it like 12 monthly reviews, or would people have to have reviews?
Yeah, I mean, if they're on diuretics, they should be having blood tests every 6 months, and they should be on an annual review with the GP. But it's always that sort of thing. Sometimes when you go back through people's history and trying to work out what was added when and why, if you've got the benefit of the sort of the computer notes, it's like Sherlock Holmes sometimes going back and finding out why they're on it. But if they are on a diuretic and they've got edema, if you're concerned about doing compression, just do a BMP, and that will help guide you. I think it's the most useful advice to give on that.
And if the edema is above the knee and it's going up into the groin and abdomen, would you say don't use any compression, or would you go?
I would
the knee?
I
Or?
wouldn't use compression above the knee. Personally, I would start with compression below the knee and get it investigated before you start to put the higher levels of compression on, because the ones that I've seen that have gone into hospital, it's usually fairly high level of compression right up both legs. That seems to be something that they just don't adapt quickly to it, and then the heart starts to tip into acute heart failure. So I would say put the minimum compression you think you can do to begin with until you get that investigation done.
Yeah, because yeah, and I think, you know, I imagine there's a lot of people in the audience and they've seen these situations. I remember a patient very vividly who had heart failure, had kidney failure as well, and they had very swollen legs, and we were being called out in out of hours and things because there was these, you know, his legs were so wet, and trying to kind of mop them up and things like that. That I guess in somebody's situation like that, where it's kind of palliative care, then if it's palliative care, would we address the symptoms and use compression, or still would we say, no, we're not going to do that? That's
I mean, I think with palliative care, it's very much, it is symptom control and patient comfort, isn't it? So that's what you're sort of looking at. I mean, it's the likelihood with the patients with advanced heart failure is that the reason that the edema is getting worse and the legs are getting worse is we've always got this really tricky balance between renal function and heart function. And they also, when they're going to sort of advancing heart failure, they stop responding to the diuretic, that fluid builds up. So I just think if some compression on the legs makes them more comfortable, then try it, but just add it in gently. Don't go for the higher levels and try and do it all in one. Just start with your lowest level and then build it up and see how you respond to it.
And Sylvia, would you say then it's kind of then bringing in another level of the, you know, MDT in you know, the palliative care team as well, I guess, with that, wouldn't it be?
When you get to that stage, yes, and you're talking about palliative, you will be working in conjunction with your palliative care nurses as well, because as Rhona says, it is all about symptom control. And, you know, even in that earlier stage before you got that, your whole aims of management is about alleviating any swelling that you can, and also trying to alleviate the pain, because you're trying to reduce the impact that the condition's having on the patient. I often find, and I've got to say just about with probably every patient that I deal with that's got a heart failure element to it, I never put any more than half a limb in at a time. So I would always start just toe to knee on one leg, probably keep them on that for anything up to the first week of treatment, to allow the body plenty of time to adjust and, you know, to allow that fluid to shift, to allow for the body to compensate for that and to excrete it in that before you then start introducing both lower limbs. So, you know, in Bill's case, I would be looking at which is the limb that's causing the biggest problem and stuff like that. When we get to that palliative stage, it is very much about comfort. So you are looking much more about putting on a modified compression. And there are various pieces of hosiery and equipment that you can use for that from a variety of the different companies.
Yeah, that's really, yeah, and I think that is will be really important messages to people. So thinking about people who are not, you know, in acute heart failure or not at the end of life, but they've got chronic heart failure, and, you know, they might have obesity and these other elements and comorbidities. And in the NHS long-term plan, there's a lot of emphasis on empowering patients to take control of their own health and care, and health coaching is really highlighted. So would lifestyle changes help in Bill's case? Sylvia, is there any advice that you would give to somebody like that?
Definitely, from my point of view, I would, as part of that assessment, you're looking at the sort of what we call the 6 S's. So you're looking at the story, you're looking at his skin, the sight, the size, the shape, his ability to self-care. So whatever I'm then going to be looking at putting on Bill's legs, I would be looking at how can we promote Bill to self-care. That also reduces the amount of impact that the district nursing team is going to have on Bill. And as we all know, district nursing fully as it is, and that's only going to get worse as time goes on. So that's where things like, you know, if you're involved in district nursing, and you might have to for the first couple of weeks of Bill, so you'd be using your short stretch bandaging systems predominantly then. But I would be very quickly looking at, is there wrap therapies or, you know, some of your ulcer care kits that could be utilised for Bill that he could cope with. And it's all about what his ability is. Now, we're talking about him being breathless, we're talking about him being slow on his feet. You know, one of the things that we're very much been promoting over the last couple of years with the British Lymphology Society is that small changes all add up to make a big difference. So even if you are encouraging patients, rather than talking about exercise, and exercise is one of the mainstays of treatment, but rather than talking about exercise and making people feel fearful that they've got to sit and do a workout program, you know, exercise is all about just increasing your activity level. So for example, when you get up to put that kettle on and the 3 minutes it takes to boil or whatever, can you just stand there at the sink holding onto the sink, marching up and down in the spot? You know, you're using those calf muscles, you're putting a wee bit of activity in there, you're helping to pump that fluid back up.
Yeah, and yeah, I mean, like foot tapping and those sorts of things.
Exactly.
It just activates, doesn't it, that foot pump and calf pump. And Rhona, I guess you do this as part of your role, don't you? You know, kind of lifestyle.
Very much so. I mean, when we go in and we've got somebody who's new diagnosis, it's very much getting them to understand what's wrong with them, getting them to understand their medication. And then again, the lifestyle, what can they do to try and improve things? And, you know, if they are overweight, maybe a bit of dietary advice. But certainly we want them to be active. And like Sylvia was sort of just small, even little bits of activity, whatever they can manage, will improve their outcome. Something we do with them is we do a sit-down hokey cokey. We get them with a tin of beans or a bottle of water, left hand in, left hand out, left hand in, shake it all about. And that's something that is fun, and it's just sort of engaging. I mean, there's practical things. Sometimes we have to restrict fluid, sometimes we have to restrict salt intake with that there. But it really is trying to get them engaged and understanding and what they can do with us between we get them to weigh themselves and keep a track of it, and then they get a sort of traffic light system. So if your weight's going up and you feel okay, keep an eye on it. If your weight's going up and you're getting more breathless, you need to phone us so that we can adjust medication accordingly. And that's giving them the responsibility then to tell us in between appointments if something's going on. So really trying to engage them and get them involved in the care.
Yeah. I love a bit of hokey cokey. That's fabulous, isn't it? In out, shake it all about.
I was at a study day with about 30 heart failure nurses, and we were all doing it, and it was very, very fun.
Oh, I bet. And again, we're adding another layer, aren't we? We're talking about diet and maybe dietitians. I know in some GP practices they have these kind of lifestyle coaches who with exercise and stuff. So there's kind of a lot of opportunities as well available.
So, Alison, I was going to say the other thing that we have to think about is one of the things you mentioned was the fact that Bill's sort of sleeping in the chair. You know, that's something that we have to address as well, because, you know, then you don't only have the edema that's there because of the heart failure, you have the edema that's there because of the dependency. So again, that's the bit of education that actually get into bed, and that's where the nurse has to become a bit of the detective and find out, why is he not going to bed? Is it the effort of getting to bed or getting from the bed to the toilet? Because a lot of these patients, you'll find that if they are able to lie down, they'll then be up and down all night passing urine, whereas they've possibly not passed very much during the day. So is that just too exhaustive for them?
Yeah.
Is it the actual physical ability of lifting the legs into the bed? You know, there's lots of things that you think be there. Is it a case of when they lie down, they're becoming breathless because they're feeling a bit overloaded in the chest when they lie down? You know, we have to address these. We can't just leave them sitting in the chair 24 hours a day.
No, and I've come across this a lot of our community nurses will out there, as you have, and it's that, and then again we're looking at social support, because if he can't manage and cope at home, you know, can he get a bed downstairs, profiling bed? So there's all these things. But I just want to move on to ask Sam a few things. Hiya, Sam, and about, you know, we've talked a lot about kind of, can we compress, can't we compress, and in Bill's case we've kind of got to the point of we know that we can, and would we need to apply compression bandaging initially, do you think, and what sort of type would that need to be if so, because he's got wet legs, hasn't he, so we need to kind of mop that up and I guess. And
yeah, I think the traditional way of treating this type of patient would be a short stretch bandage, where we know that they're designed to give some resistance against, especially the calf muscle pump, and this is why they're so effective. So as the patient moves their limb, they meet the resistance of the short stretch bandage, and that encourages the fluid to move out of the limb. What we've found recently is with the introduction of adjustable Velcro devices, compression wraps, and especially during sort of COVID times, where community practitioners are moving more and more towards these compression wraps with the ethos of supported self-care. So just to understand a bit more about compression wraps, is there tends to be but two types on the market. Most companies provide compression wraps, but you get the ones that interlock, so the straps alternate when they fasten, or those straps that they overlap. And if we think of short stretch and long stretch bandages, or even bandaging techniques, which I'm sure most of the audience tonight will understand, if we layer compression up, we are creating a stiffer environment for that limb. So I would say in this case, we're probably looking, if we can't provide a short stretch bandage, of using a compression wrap that overlaps to ensure we are getting that stiffness that we need, the static stiffness, which is its proper name, or the resistance to help encourage that fluid out of the limb. And the other aspect we need to think about here is we've got a lot of lymphorrhea, or leaky legs is a common term. So with these patients as well, if we were to pull on hosiery, and I think it was Sylvia mentioned potentially hosiery kits, we need to think about the dressings underneath as well. What sort of dressing are we going to put on that limb? And if we are we going to dislodge it by applying a compression garment or compression device? And what I would say is, if you are going to have dressings on that limb, think about the amount of exudate that's coming out of that limb, and try and find a super absorber that is effective enough to absorb the amount of fluid that that leg is producing. And also make sure you apply a good quality super absorber, because they're all made slightly differently. And again, if you want a bit of advice or guidance, there is the CET report, which highlights the different types of super absorbers and which ones are best under compression.
Okay, and with because Rhona and Sylvia had mentioned about you know, initially reduced compression, and with the short stretch bandaging, and I know this is a TVN, you can put different levels on, can't you? So you can put like one layer on initially, and the short, it's great, the short stretch, isn't it? Because it's almost like if you kick a football into a net with long stretch, it'll bounce, you know, back, but it's like a rigid wall, isn't it? With short stretch, it's not going anywhere, it's containing it in there. And so we could do reduce with that, couldn't we? And with the wraps, are they reduced compression in wraps and hopefully as well?
So again, it depends what you've got available within your working area, but wraps do come in different compression levels. So like Rhona and Sylvia have both said, what we don't want to do is squeeze both limbs from toes to thighs straight away. We need to do this gently. So this is where your clinical judgment comes in. So do you apply one device just below the knee, but in sort of the 30 to 40, round about what we would expect at a normal level of compression, and just pop that one garment on? Or are both legs leaking, where we might want to then address both legs at the same time? But because we don't want to push that fluid too quickly, we might look at a reduced level of compression. And this is where, again, you might want to make sure we do liaise as a multidisciplinary team, because what can happen with lymphedema, if we just treat below the knee, is we shift the problem to the knee, which then causes more problems with mobility and such like. So if we do find we're moving the problem to above the knee, I would suggest we potentially speak to someone like Rhona for a bit of advice about then continuing that compression up the limb. But again, slowly and surely, it's gradually, let the heart adjust, let the body adjust.
We've had some amazing advice from everybody's, you know, a specialist in their own right here, and it's fantastic. And I know I'm just thinking about best practice guidelines for people to access and look up, and pathways to follow. And we mentioned the British Lymphology Society guidance. Are there any others, ladies, that you can think of? I can think of at the top of my head, because one I was involved in, which is the best practice statement for venous leg ulcer complexities, and that touches on heart failure and like lymphedema and edema within that. Is there anything else that we're missing that people can take that message home? Shout at me.
I was going to say, I would think of just keeping in the back of your mind the likes of the consensus document on the management of cellulitis with patients with chronic edema, because, you know, the one thing that we all know is you don't get such a thing as bilateral cellulitis, or at least it's very rare, but yet we still commonly have antibiotics being prescribed for legs that are red, but yet not necessarily any great evidence of an infection there, so therefore not getting very good results. So I would potentially say be aware of that one. And then also, again, thinking of chronic edema, the Welsh, I'm trying to remember the name of it, there's the Welsh wet leg chronic pathway.
Yeah. And then nice guidelines, Rhona, of the heart failure.
Yeah, so the main guidelines so in Scotland it'll be the SIGN guidelines.
Yeah.
And England has got the NICE guidelines. You've also got the European Society for Cardiology. They've got their guidelines as well. And if you're interested in any of the trials on heart failure, it lists all of them and the sort of most up-to-date treatments. But that's the two that you would go to initially. Another good resource if people are interested, British Heart Foundation has got a fantastic website and lots of resources. And we've also got a charity that they work with called Pumping Marvellous, which is another charity. They do a lot of leaflets and publications and events for things as well. So that's one just to Google and go on to internet with.
Yeah, that sounds good. And we have to remember, it's not just for us as clinicians, it's for our patients in that supported self-care, isn't it, as well? So they understand their conditions and, you know, and can then, you know, help themselves with, you know, the lifestyle stuff and understand, you know, what's going on and treatments.
And the better they understand it, the more empowered they are to look after themselves. And, you know, it's not anything to do with age, or I've got some older patients who self-manage brilliantly. It's just generally their understanding of the condition. The social support makes a big difference. How unstable they are, and particularly if they're having lots of admissions to hospital, we keep on to them. But the majority, it's really give them the information and get them to self-manage, and then at any point come back to us if they start to run into trouble again. That's really just to keep the caseload moving and making space for the new referrals that we've got coming in.
Yeah, and for people to then go to their MDT teams and look at their local guidance and policies and things that possibly are already in place there. I'm going to move on to this has been so fantastic. It's so interesting. I've learned so much. But we've got questions that are flying in from our audience. Everybody's obviously loving this. So I'm going to move on to that. So we're going to have plenty of time to answer everybody's questions that are coming. So our first question is from Fanny, and it is for Rhona. And Fanny is asking, and I want to know this too, how do we tell if it's a cardiac cough?
The cardiac cough generally is quite a dry cough, and they tend to it's like a white frothy cough. It's not that sort of gunky stuff that comes up from the lungs. It's very very white and frothy. So if they're saying white and frothy, then that would be suggestive of sort of cardiac rather than respiratory cause underneath.
Yeah. Oh, that's really good to know. And then our next question is for Sylvia, and it's from Julie, and she's asking, what would you class as a basic level of compression?
Realistically, something as simple as I've seen for myself. I've used things where for patients it's as simple as a tube of gauze with some wadding and then another tube of gauze on top as a starter layer. I've then also seen it where it's a basic 2-layer where you're putting on your super absorbent, your wadding, and then a crepe type bandage. A lot of it is you have to work with the patients and build it up. And obviously, even if you're putting something like that on, you're then going to get slippage in that, which is going to cause some problems. But once the patients start to see an improvement, you can usually find that they will work with you. But my aim would always be to try and get into something like your short stretch bandaging quite quickly, because that's where you're going to see the biggest difference.
Yeah, and we have the immediate care, don't we, advice now in our, with the National Wound Care Strategy Programme of, in the absence of red flags and to err on the side of caution initially, that we can apply a 20 milligrams mercury of compression until we can get then the full assessment done, obviously taking into account the heart failure and everything else, but it's just to note that that is there. So thanks, Sylvia. Our next question, we're back to Rhona again. This is Heather, and she's asking, are there any treatment pathways for heart failure management that are available for people to use?
Yeah, so the path, there's in the NICE guidelines and in the ESC guidelines, they've got a pathway for diagnosis, and then they've got a pathway for treatment, and that's in both the guidelines. I have to say a lot of the treatment is more for left-sided heart failure. It's had more research done. So when it's reduced ejection fraction, there's less options there. Within that pathway, I talked about medication, but that might also lead on to cardiac right resynchronization therapy, which is a pacemaker with an extra lead, which can, with or without a defibrillator. And also some of our patients will go on to possibly transplant as well. So there's different ones there. But within the European guidelines and the NICE guidelines, they've got definitely NICE guidelines that they've got a pathway for diagnosis, and then they've got a pathway for treatment that you can look at.
Yeah, you know your stuff, don't you? And the question, we're going to Sam. Is it common practice, Sam? We talked about compression, we talked about that superabsorbent. Is it common practice to use a superabsorbent under compression?
I think it's one of these things. There seems to be a lot of misinformation, I don't know if that's the right word about, and a lot of reluctance to use superabsorbers under compression. And there's a fear that if you use compression over a superabsorber, you're going to stop it working effectively. And this is where I'd refer you back to the study that I mentioned earlier, is to have a good look for yourself to the superabsorbers that are out there that you know you can use under compression. There's good ones and bad ones in the market, like everything else. But what we're trying to do is we're trying to turn the tap off on these leaky legs. We're trying to protect the skin as much as possible. So the best quality super absorber that you can get your hands on for your patient to encourage that fluid away from the skin is really going to help protect the skin, and then make sure you put that compression on top.
Yeah, and I think from my experience as well, I agree with that as well, Sam. And I think there's been this historic thing about, oh well, it'll affect the amount of compression if you put a super absorber underneath. It won't, and it's about looking after the skin, isn't it? So once we get that under control, and that's how we do that, then we can then step down and we don't need to use that. But initially, like in Bill's case, it's looking like, we couldn't get away without using that. Christine is asking Sylvia, would you refer Bill for a duplex scan?
With what we've been given there at the moment, probably not, in that my first stage would be to use my handheld Doppler. And actually, chances are, because of the edema, I possibly wouldn't be able to palpate any foot pulses, but I would certainly be using my handheld Doppler to actually listen to them and actually try and determine what sort of pulse have we got. Have we got a monophasic or a biphasic or a triphasic sound? And obviously, we're looking for that by a triphasic sound, because that gives us the indication that there's much more suitability there for compression, and that we're safer to compress.
And I guess when we've got things under control, then it's a consideration and a discussion, isn't it, whether that is
exactly, because the chances are, once you've got the wounds dried up and you've no longer got the lympholia, you've potentially got less edema, you can then go on and do a Doppler then, and then depending on that, if you felt that there was the need for a duplex, you could. Obviously, if you've got signs and symptoms flagging up to your peripheral artery disease, so you've got reduced peripheral refill and things like that, then obviously, referral to vascular at a sooner state would be appropriate.
Yeah, and which is part of our red flags, isn't it? That
it is.
To identify that, yeah. Rhona, Kirsty's saying, if the patient's got fluid overload, would they be on a fluid restricted diet? That's a really good question.
We sometimes put patients on fluid restriction because it's not most scientific treatment for it. There's not a huge amount of evidence, but for some patients it just works. So generally, if we feel the symptoms are unstable, we would normally sort of suggest a 1.5 litres as a fluid intake, and then obviously on a hot day like today, they can have a bit more, up to 2 litres. But for some patients, they certainly shouldn't be having more than 2 litres fluid wise, because that will just make it can worsen the edema.
Yeah.
I had a gentleman recently, when we got him to measure his fluid, he was actually consuming 4.5 litres a day. He was a retired builder and was just drinking buckets and buckets of tea. And when he reduced it, it made a significant impact on his diet. So it's a useful thing. I think the problems we have is if you've got patients with catheters, you've got to weigh up the balance of getting enough fluid for avoiding problems with that. So we tailor individual to patients' circumstances, but in general, we advise sort of 1.5 litres, 2 litres of fluid to restrict.
Does the hot weather like it is at the minute? Does it have that effect? I know we've seen a lot more of like leg ulcers, that breaking down and things like that when it's hot. Will it affect with the heart failure and the swelling?
Yeah, I think with the heart failure patients, the heart failure and the respiratory patients, they really struggle with hot weather. They really do, because the body's ability to adapt to the temperature changes is not as good as it is with somebody without an underlying illness. Where we see sort of peaks in activity and what happens when we look at our sort of caseload over the year, we get a peak in the spring and we get a peak in the winter and the autumn. And the commissioners laugh at me because I say, well, the clocks have changed, so here come the referrals, and it's patients adapting. It's either sort of the weather's cooling down, so in the autumn, but in the spring you've got the patients who've been sort of hibernating and then they start to become more active again. So it's not generally in the middle of the summer we see the issues. It's actually in the spring and the autumn with the changing of the clock.
Yeah, that is so interesting, isn't it? Yeah. Sam, would you recommend bed rest at all for patients with very swollen legs as a treatment?
Do you know, that was something that was maybe around when I started my nursing training years ago, but as much as possible, we'd encourage some sort of movement. Now, obviously, if your legs are sore, if you're struggling to mobilize and sort of walk around the house safely, then we would encourage you to especially raise your legs. But what we would want to encourage is some sort of program of movement, shall we say. So doing simple things like pointing your toes to your nose, then pointing them away, sort of isometric exercises, so clenching your muscles and then releasing. If we just had our patients that were confined to bed, it may well actually make the problem worse, because it's this calf muscle pump and the muscle compressing against the compression that's going to help push that fluid out of the limb. I don't know if that's answered completely, but it's maybe given a little bit of direction. Ideally, no, but if it's a safety aspect and if they're struggling, yes, but we would still want the patient from a lymphedema point of view to be encouraged to do some sort of movement and exercise.
Yeah, I can see the thought of the person there and kind of how that it kind of used to be, but yeah, it makes sense to exercise, doesn't it? Definitely. We kind of touched on this before, but Demi's asking Sylvia, when would you refer to lymphedema? And I just think this is really important, because we know there's a massive lack of lymphedema services around the country, and there are some pockets where it's, you know, the services for people with post-cancer diagnosis, and some places it's not with active ulcers. So, you know, would you refer, and how do you do that?
Right, well, referral to the lymphedema services around the country will vary. So all I could say is go and ask the question yourself in your own areas. Certainly within my area, because I'm a new service, I am prepared to take referrals for, I won't say the simplest of things, but if district nurses have had patients on their caseload and they're just really struggling to manage something, whether it's got ulceration or it hasn't got ulceration, I am happy for them to send me an email, send me some photographs for us to have that MDT discussion and to try and come up with a plan of treatment. So yes, it is a referral into the service, but it's not necessarily one that I'm going to see. For most lymphedema services, we're looking for the more moderate to complex levels of lymphedema. So you're looking at limbs that are grossly misshapen. You're looking at limbs that when you feel the skin, it feels woody, you've got skin changes, you've got papillomatosis, you've got that real deep orange peel effect to it, all those sort of things. And if you've got things like that, I would say that's the time certainly to be involved in your lymphedema services.
Okay. That's great advice, thank you. I'm really conscious of the time, and I don't know about anybody else, I'm getting hotter and hotter. I need an ice cream. So thank you for all your questions. That was fantastic. And if we haven't been able to answer some, in the next few days, we will go through them and we'll get back to everybody and give you your answers. So I'm going to hand back to Claire now and to finish off our evening. So have a great evening, everybody.
Thank you very much, everyone. That was really fascinating. And there's a lot of comments that I've been looking at during the session, and their appreciation for the advice has been fantastic. Yeah. We've also had an expert panel within the audience who've been really helpful as well. So we've all been sharing and caring for everyone. So a wonderful session. So thank you again to all our speakers, to Rhona, Sylvia, Sam and Alison for facilitating the discussion. And thank you, Essity, again for your support. Essity have many support and educational tools, and if you would like any further information at all, then you can email concierge.service@essity.com or ask your local Essity account manager. Essity also have a range of products that you might be interested in. So again, contact your local account manager or the concierge.service email address. The email is on the screen now, so for the comment in the comments section for the certificate link, the recording and the slides will be available on our website very shortly. And if you like our Wound Care Today Facebook page, you can keep up to date with any new events as they happen. So that's all from us this evening. Thank you for your attention, everyone, and we hope to see you all again soon. Have a lovely evening. Good night.